The anatomy of external layer. External layer consists of pinna and external auditory meatus. It is made up of fibroelastic cartilage covered by skin and connected to the surrounding part by ligament and muscles. It is developed from the first and second branchial arch that is called helicophysis between 6 to 28 week. Various landmarks on the pinna are helix, antihelix, lobule, tragus, concha, scaphoid fossa, and triangular fossa. You can see in this picture. Pinna has two surfaces, medial and lateral surface. The Simba conchi lies between the crus helix and crus antihelix. It is an important landmark for mustard antrum surgery. And you can see the Betty is the most common congenital anomaly of the pinna in which antihelix has not developed and excessive conchal cartilage is present. The correction of pinna mostly done at 6 years of age, that is called otoplasty. In bat ear, Simba conchi is large and prominent ear like bat with antihelix is underdeveloped. There are both extrinsic and intrinsic muscles of the pinna. Extrinsic muscle are anterior, posterior, and superior auricularis. Intrinsic muscle are helicis major, helicis minor, tragicus, or antitragicus. So there are three extrinsic muscle and four intrinsic muscle. Both group are supplied by the branches of facial nerve. The sensory supply of the pinna. Now talk about first lateral surface. Upper two-thirds of lateral surface is supplied by auriculotemporal nerve, which is branch of the fifth nerve, and lower one-third by the greater auricular nerve, which is originated from the C2 and C3. Medial surface of pinna is supplied by lower two-thirds by the greater auricular nerve and upper one-third by the lesser occipital nerve. There are two nerves which supply the cavum conchi, part of external auditory canal between pinna and EAC, that Arnold's nerve. It is a branch of vagus nerve, and this branch of vagus is also called Elderman's nerve. And same part of this facial concha is also supplied by facial nerve in some area of the this cavum conchi. The blood supply of the pinna. Posterior auricular branch of external carotid artery, superficial temporal artery, a branch of external carotid artery, occipital artery, same branch of external auditory artery, and vein corresponding to the arteries drain into external jugular and common facial vein. Lymphatic drainage, they are drain into parotid group, upper deep cervical, preauricular, and post-auricular lymph nodes. Now talk about external auditory canal. Developed from the dorsal end of first branchial arch between 6 to 28 week. At birth, only cartilaginous meatus is present because the bony part develops from tympanic rim, which is an incomplete form at the time. Bony part of meatus is absent in newborn. In adult, its length is about 24 mm, outer one-third being cartilaginous and inner two-third 16 mm being bony. The canal form a mild S-shaped curve directly medially upwards and forward, and then medially backward and downward. So you have to manipulate ear according to the age, young or adult, in particular direction to see the tympanic membrane. The canal has two constriction of in one near the medial end of cartilaginous part and another being 5 mm short of tympanic membrane in the osseous part called isthmus. Floor and anterior wall of meatus are longer than the roof and posterior part due to oblique position of tympanic membrane. Anterior and inferior walls are formed by the tympanic part of temporal bone. Roof and part of the posterior wall is formed by the squamous part of the temporal bone. So it is formed by tympanic and squamous part of the temporal bone. So there is one is foramen of Luske. It is a deficiency in the anteroinferior part of the bony meatus. Close to it closes around 4 years of age. Another is fissures of Santorini, a deficiency seen in cartilaginous part of the EAC through which the infection of mustard and parotid gland can spread. The important relationship of EAC are condylate process of mandible is close relation to the anterior wall. Middle cranial fossa lies above the osseous meatus and mustard ear cell are posterior to it. And below you can see styloid complex. So these are the important relationship of external auditory canal. The nerve supply of external auditory canal. Anterior and superior walls come through the auriculotemporal branch of mandibular nerve. Posterior and inferior walls are supplied by auricular branch of vagus, that is Arnold's nerve, and a sensory branch of facial nerve. Nerve of wristwork may supply a part of the posterior wall of the meatus. Then this is the nerve supply of external auditory canal. So this is all about external ear. Thank you so much. The frequency of hearing of human ear is about 20 to 20,000 hertz, but best frequency for external ear is about 30 to 3000 hertz. So best frequency at which the external auditory canal is resonate is about 2000 hertz. So external ear and pinna act as a collection of sounds. So this is the role of the pinna in external ear for the hearing. Today's topic about earwax. Earwax is a sebaceous gland produced in oily material called sebum, which ultimately break down into desquamated cells in the hair follicles. And the wax is a mixture of desquamated cells, cerumen and sebum. And it is usually two types, dry wax and wet wax. Sometimes there is intermediate type also found, that is mixed wax, but primarily the mixed wax is under the wet wax only. The wax mixture of desquamated cells rumen is gene responsible for type of wax is ABCC11 gene. This is the single gene which is responsible for wax type, and it is Mendelian trait. If you see, dry wax is lacking cerumen in yellowish gray and brittle in color, whereas wet wax is brownish and sticky, and where mixed wax is common in between the mixture of dry and wet wax, it's common in Americans. Whereas dry wax common in Asian populations and wet wax common in European and African population. It shows Mendelian trait. If A married to G, it means the dry wax married to wet wax. Mostly G, yeah, it means wet wax is dominant trait. So if you see the product of this A and versus G, AA means dry wax, GA, GA and GG is wet wax because of wet wax is dominant, G is wet wax. So dominant trait is wet wax, and it shows representation of ABCC11 gene which decide the type of wax. The benefit of earwax. The primary role of earwax to protect the skin of ear canal. It acts as a protective layer, trapping dust, other small particles that could make their way deep inside the ear where they could cause damage. Earwax also has antibacterial properties that can prevent infection. A waxy buildup in the ear canal help prevent water from getting there, which reduce the risk of ear infection. Earwax stickiness and smell both are essential properties. The stickiness traps dust debris from entering the sensitive part of eardrum. And earwax also act as a moisturizer, and it also protect the thin tympanic membrane. So it is more protective role. When earwax is becoming a problem, then you have to consult the doctor. You should not clean the ear because it's not required. Most of the time ear is protective, earwax is protective. If any sign is present like pain and pressure in the ear, there is ear blockage, tinnitus or ringing in the ear, or odor or discharge coming from the ear, and there is temporary hearing loss because of blockage, then you should consult the ENT doctor. You should not clean the ear. Routinely, ear cleaning is not recommended, not required. So, this video is about the earwax. How to, there is two type mainly, wet and dry wax, and ear cleaning is not recommended because it's protective. That's why this is, if you search out about earwax, if creating problem, then consult the ENT doctor. Thank you so much. Hi guys, this is about ear syringing. This is Simpson's oral syringe. The syringing should be done in posterior superior direction. Pinna is pulled upward and backward. Water jet is directed along the posterior superior wall because external auditory canal is straightened. Posterior inferior wall of external auditory canal is supplied by vagus nerve, so we should not direct in the posterior inferior direction of external auditory canal. So complication may be vertigo because of caloric stimulation, rupture of tympanic membrane, and reactivation of quiescent otitis media if perforation is there. So this is all about syringing. Thank you so much. Today's topic about tympanic membrane. Tympanic membrane is a semi-transparent. You can see this picture. It is not completely transparent. It is semi-transparent partition between the external auditory meatus and tympanic cavity, or you can say middle ear. It is an oval shape, about 10 mm tall, 9 mm wide, and 0.1 mm thick. So thickness is very less, 0.1 mm. It is placed at angulation of about 45 degree to the floor of external auditory canal. It consists of three layers. Outer cuticle layer, that is stratified squamous epithelium, developed from ectoderm. Middle fibrous layer, developed from mesoderm, and inner mucosal layer, that is developed from the endoderm. And inner mucosal layer is low columnar epithelial layer. The color of normal tympanic membrane is pearly gray or pearly white in color. So there are two parts of normal tympanic membrane, is pars tensa and pars flaccida. Pars tensa is larger part and its periphery thickened and form a cartilaginous ring. That cartilaginous ring is called annular tympanicum. That fits in the bony sulcus, that is called tympanic sulcus, which is formed by the tympanic bone mainly, and that is bony, and it's above deficient, and deficient part of this bony sulcus is called notch of Rabinus, which having the another part of tympanic membrane, that is pars flaccida. And this pars flaccida between the anterior and posterior malleolar ligament is also called Sharpnell's membrane, that is Sharpnell membrane, and it is small triangular in shape. This part, pars flaccida, is triangular shape and it is between the anterior and posterior malleolar fold. It is thin because it doesn't have any fibrous layer. So this part deficient of the fibrous layer of the tympanic membrane. The fibrous layer of pars tensa having three type of fibers. The most lateral fiber toward the external auditory canal are radial fibers which radiate from the umbo toward the periphery. So in this fibrous layer, most lateral fibers are radial fibers. Another fiber just inside to the radial fibers is circular fiber of fibrous layer. In between intermingled fibers are parabolic fibers. So these fibers are made up of collagen bundles. So outermost fiber in fibrous layer is radial fiber, then circular fiber, then in between intermingled fiber are parabolic fibers. So there are three types of fiber in middle layer, fibrous layer of tympanic membrane. You can see in this picture the layer of outer layer, that is cuticular layer, then followed by fibrous layer, and inner mucosal layer is low columnar epithelium in the section or histology of this tympanic membrane. So tympanic membrane having two surfaces, lateral surface and medial surface. As you can see in this picture, the lateral surface is concave towards external auditory meatus. It divided into four quadrants by the two imaginary lines. First imaginary line passing through handle of malleus and another line passing through the tip of the handle of malleus, or you can say umbo, at the right angle to the perpendicular line of handle of malleus. So there are four quadrants. Anterior inferior quadrant, you can see cone of light is there. Antero superior quadrant, posterior superior quadrant, and posterior inferior quadrant. So cholesteatoma is most commonly occurred because of retraction in the posterior superior quadrant. The medial surface of tympanic membrane is convex and maximum point of convexity is called umbo. Umbo is the attachment of handle of malleus on the tip of tympanic membrane where maximum convexity is towards the middle ear cavity. You can say tympanic membrane. The cauda tympani, you can see in this picture, is closely related to upper part of tympanic membrane, that is pars flaccida. Nerve runs from posterior to anterior aspect, medial to the neck of the malleus, close to the tympanic membrane. The relationship of tympanic membrane. Laterally, it is external auditory canal. Medially, there is tympanic cavity. Superiorly, you can see there is middle cranial fossa. Inferiorly, being jugular valve. And anteriorly, you can see there will be TM joint, and posteriorly there are mustard cavity. So these are the relationship of the tympanic membrane. The nerve supply of tympanic membrane. Lateral surface supplied by two nerves. Anterior part is supplied by the auriculotemporal nerve, and posterior half of lateral surface supplied by vagus nerve, that is Arnold's nerve, and medial complete surface of medial is supplied by the Jacobson's nerve, that is a branch of the glossopharyngeal nerve. Now blood supply of tympanic membrane. There are three artery supply. You can see first is anterior tympanic artery going through petrotympanic fissure, and deep auricular artery going through scomotympanic fissure into the middle ear cavity and supplying the tympanic membrane. They are both artery. This anterior tympanic and deep auricular are branch of first segment of internal maxillary artery. Another artery which is supplying below is the stylomastoid artery, is branch of the posterior auricular artery. So overall tympanic membrane supply by the mainly external carotid system, and venous drainage mainly in the external jugular vein laterally, and medially there is auditory plexus which is going into sigmoid sinus and transverse sinus. Today's topic about middle ear anatomy. It is better is middle ear cleft, having editus, antrum, attic, eustachian tube, tympanic cavity in mastoid ear cells. You can say the middle ear or tympanic cavity is six-sided box, and highest dimension is epitympanum about 6 mm. So this is middle ear cleft picture you can see. In middle ear is six-sided box. Roof of middle ear mainly formed by the tegmen tympani extending from tensor tympanic canal up to the editors. So whole length of roof is covered by the tegmen tympani of the tympanic cavity. Floor is thin layer and mainly formed by the jugular wall and sometimes may be deficient, and where it is a small canal is there that is called tympanic canaliculus, which Jacobson's nerve passes through between the internal jugular valve and the ICA, and laterally is covered by the almostly by tympanic membrane and bony outer attic wall that is called scotum, and erosion of this is sign of cholesteatoma. And posterior wall separate middle ear from the mastoid ear cell, editus and fossa includes pyramid vertical facial canal, posterior canaliculus, which the chorda tympanis passes through, is part of posterior canal. Anteriorly, you can see eustachian tube and tensor tympanic canal. And medially is cochlea, anterior oval window. There is hook-like bony projection called processus cochleariformis, tensor tympani tendon, which turns around medially, and it is also mark of the facial canal. Hi guys, this is endoscopic anatomy of the ear. Binocular vision best in microscope, both ends are free. Endoscopic having wide and panoramic view is better visualization. As you can see, the endoscopically middle ear is divided into five parts: epitympanum, protympanum, mesotympanum, retrotympanum, and hypotympanum. These five areas are very important for know each and every structure of the middle ear. Now talk about retrotympanic area. As you know, retrotympanic areas are having many bony crest and sinuses. First bony crest you can see is ponticulus. Its connection between the promontory and pyramidal eminence classified as bridge ridge or incomplete. And there is another crest that is subiculum. Its bony structure arising from posterior pillar of the round window next toward the styloid eminence. You can see it is just like bridge ridge or incomplete like ponticulus. Funiculus is conjunction of anterior pillar of the round window niche that up to the jugular bulb, classified again as bridge ridge and incomplete. So there is retrotympanic sinus like posterior sinus is triangular area which is limited laterally, posteriorly and superiorly by facial nerve, inferiorly by ponticulus and anteriorly by the stapes footplate and oval window. Sinus tympani round shaped sinus between the ponticulus and subiculum. And sinus subtympanicus is area between the subiculum and funiculus connected with the round window niche anteriorly. So these sinuses, posterior sinus, sinus tympani and sinus subtympanicus are, you can see in this picture, are important for hidden areas in the cholesteatoma surgery. Like ponticulus variation, it may be barrier, communication and true bridge. Barrier means completely there is no gap between sinus tympani and posterior sinus. It allow direct in B type. It allow direct communication between sinus tympani and posterior sinus, and true bridge is there. You can pass between the sinus tympani and posterior sinus. Subiculum is also having same variations, like it may be varied communication bridge between the sinus tympani and sinus subtympanicus. So these variations are important to know in the middle ear surgery. And sinus tympani may be having three types. It may be shallow, it may be deep, which going to the facial nerve. It may be extend beyond the facial nerve postomedially. So three type of sinus tympani can be seen in the middle ear. So these crest and sinuses are mainly situated in the retro and hypotympanic areas. Now talk about epitympanum. Epitympanum divides entirely by epitympanum and posterior epitympanum by cog. Cog divide anterior and posterior epitympanum. What is cog? Cog is transversely located crest which from the tegmen to the malleus or behind the cochleariformis process. It is also called transverse ridge crest and it is located behind the cochleariformis process which is the fulcrum for the tensor tympani. Process space between the lateral process of malleus inferiorly, pars flaccida laterally and neck of malleus medially. And laterally you can see malleolar ligament superiorly also. So these process space are more prone for cholesteatoma cholesteatoma disease. You can see this process space in the picture. And you can see antitympanic space for the ventilation of the middle ear. There is two isthmus, antiisthmus and postisthmus, which ventilate the epitympanic area, which ventilate the mustard cell through the epitympanic area. You can see this is a middle ear pressure homeostasis or gas exchange. Now talk about protympanum. Protympanum is anterior to the annulus, having canal for tensor tympani, supratubular recess, and eustachian tube. Superiorly, it is having tensor fold. Medially, lateral part of carotid canal, and inferiorly is a protympanniculus. Proteniculum. Proteniculum is a ridge between the hypotympanum and the protympanum. It may be have ridge, bridge, and absent. Hypotympanum is inferior to the annulus up to the jugular bulb. Depth about 5 to 10 mm. Now talk about mesotympanum. Mesotympanum is the middle area which can be easily accessible by microscope or endoscope. You can see it every like mainly handle of malleus and incus. What is McEwan's triangle? It is having superior supramustard crest, anteriorly posterior margin of bony external auditory canal, and if you pass a tangent line from the external auditory canal posteriorly, you can see McEwan's triangle for the mustard antrum. You can open the mustard antrum without seeing major structure through this approach. That is McEwan's triangle. So these triangles are very important and basic to know. What is Trotman's triangle? Trotman's triangles having superior petrosal sinus, posteriorly sigmoid sinus, and anteriorly there is a bony angle of all semicircular canals. So these triangles are basic to know for operation in the transmustard approach or middle ear surgery. So this is all about basic of endoscopic anatomy of the middle ear. Thank you so much. Hi guys, today's topic about otitis media with effusion or glue ear. You can see the picture of glue ear. What is glue ear? It is accumulation of mucus within the middle ear cleft more than 3 months. It is a chronic condition. Cuboidal middle ear mustard mucosa replaced by the thicker pseudo-stratified mucus secreting epithelium with varying degree of specialization. Submucosa having inflammatory cells, edematous and inflamed dilated blood vessels. The composition of effusion you see, there is glycoprotein mucin predominantly, IgA, lysozyme, interleukins, inflammatory cells, and cytokines. About 66% of this effusion is sterile, 34% may have streptococcal pneumonia, Haemophilus influenzae, Moraxella catarrhalis, and 92% showing biofilms in the middle effusion fluid or adenoid site. What are the risk factors are? Craniofacial abnormality like cleft palate, cleft lip, Down syndrome. GRD mainly pepsin induce the middle ear effusion. Allergies, smoking mother, child not on breastfeeding, low birth weight and low socio-economic class. It's common in male and female 1:1, 2 peaks 2 year or 5 year of the age. What is diagnosis? Diagnosis mainly clinical history of normal pregnancy, low birth weight, hearing loss, behavioral changes. PT and older children showing 80% of cases carrots notch. Automicroscopy is 94% when you are inserting the grommet. Pneumatic otoscopy, TFT, and tympanometry. The tympanometry combined with otoscopy, if showing B tympanogram 98% sensitive. If otoscopy is normal and tympanometry showing A curve, there is no chance of OME. So, if you see classical OME, there is B type of curve and C type sometimes. Treatment mainly medical is not recommended because topical steroids are not effective. Systemic steroid effect only for 2 weeks. Antibiotics are not effective. Anti-allergic decongest not significantly effective. Homeopathy not effective. Surgical management mainly laryngotomy without grommet is not recommended because incision closes within few days and effusion reoccurs. Laryngotomy with grommet insertion are effective, and with adenodectomy it's most effective. With grommet insertion with adenodectomy should be recommended in each and every child who are symptomatic like this. We have to insert grommet as well as do adenodectomy. 50% resolve self-resolving disease. It's resolved in 50% cases and 50% required some form of the treatment. So it's all about laryngotomy. It's all about OME or glue ear. Thank you so much. Hi guys, this topic about traumatic tympanic membrane perforation. It's occur as result of pressure wave in the external ear canal. You can see this picture, and causes are mainly slapping because of domestic violence about 50% cases, self-inflicting injury about 25%, others like diving and flying about 25% of cases. Male commonly affected about 60%, female 40%, and left ear is commonly involved. A small perforation about 60% and medium perforation about 20% and large proportion about 10 to 12% only. Average healing time of about 1 month and about 90% heals spontaneously, not require any intervention or tympanoplasty. In quadrant, mainly posterior quadrant is involved 30% and multiple quadrant involved about 40%. So most common quadrant is posterior inferior quadrant involved and multiple quadrant involved about 40%, and these heal spontaneously. So this is all about traumatic tympanic membrane perforation. Some cases required tympanoplasty or ossicoplasty, only about 2 to 5% of cases. Thank you so much. Hi guys, this is middle ear barotrauma. You can see the tympanic membrane congestion or arrhythmia because of pressure changes, and this is the eardrum perforation. If you ascend from the surface about 80 km, the oxygen saturation is about 0, and at surface the oxygen pressure is about 1 atmospheric pressure. If you are going depth about 60 meter, the atmospheric pressure is going to increase about 5 atmospheric pressure. If you are diving, there is compression syndrome. If you are ascend from the surface, then it is decompression syndrome. For middle ear, there is middle ear trauma because of eustachian dysfunction, which are not going to compensate the external ear pressure or middle ear pressure. If pressure during descent is increased on external ear side, there will be eardrum retraction, and ultimately if rate of descent is higher, then eardrum perforation is common. At about 80 km from the surface, there is oxygen saturation is almost nil. In that case, the external ear pressure is less and middle ear pressure is higher. Then in this situation, tympanic membrane is going to be bulged. and there will be mucosal edema in both situations. During ascent or descent there will be mucosal edema, but during descent there is retraction, and during ascent there is bulging of tympanic membrane because of pressure changes in the middle ear. And during descent there is negative middle ear pressure. During ascent from the surface there is positive middle ear pressure than the external ear. And this is the Boyle's law, in which at constant temperature, pressure is inversely proportional to the volume. If pressure is higher, the volume of air will be less. If pressure is less, then volume will be higher. Same law is Henry law. In Henry law, if you increase the pressure, the dissolution of particular gas is higher. If you are decreasing the pressure of the air, then dissolution of particular gas is less. So this is Henry law. Both law are applicable in the middle ear barotrauma, so that you can better understand the middle ear pathology. Most of the patient coming from us from ear attendant mainly. These type of patient come to us, main complaint is ear fullness, giddiness or ear pain. If you see during descent, classical presentation will be, if eustachian tube is functioning well, so there is equalization of middle ear pressure. If there is no middle equalization, then middle ear pressure is not going to compensate, and there is ultimately retraction of tympanic membrane. If rate of descent is higher, there is perforation because of external side pressure is higher. In both situations, the mucosal edema is there. This is modified Teats classification, in which there is symptom, no sign. This is grade 0 of Teats modified classification. Grade 1 is redness and retraction. Grade 2 is intratympanic membrane hemorrhage. Grade 2 and grade 3 is gross tympanic membrane hemorrhage, and grade 4 is hemotympanum, and grade 5 is perforation of tympanic membrane. In both situations, hemotympanum and perforation, we have to wait for 3 months for conservative treatment. Mainly decongestant is given. If hemotympanum persists, we have to do laryngotomy. If perforation persists, we have to do tympanoplasty. According to the grade, we can manage the middle ear barotrauma. And most of the treatment is symptomatic. And this is O'Neill's grading. In this, grade 0 is normal, grade 2 is mild congestion, grade 1 is mild congestion, grade 2 is perforation and gross intratympanic hemorrhage. So this is 3 grading only. Grade in O'Neill's classification, grade 0, grade 1 and 2. So these are 3 graded in the O'Neill's classification. And if you see grading of treatment, if there is clinical sign and symptom persist, if there is no clinical sign or no symptom, then you have to give only painkiller. If there is sign and symptom persist, you have to give decongestant, painkiller. And if there is perforation or hemotympanum, then you have to treat with medical management as well as surgical management, like laryngotomy and tympanoplasty mainly. If you see endoscopically there is eustachian tube dysfunction is persist, then you can do eustachian tube ventilation surgeries, and you can do ballonoplasty of eustachian tube so that its patency will be maintained. So these are the common surgeries we can do in the barotrauma. So most of the barotrauma patients are coming because of pressure changes, and we have to give only medication that is required is painkiller most of the cases. And these type of cases, if these allergy or any eustachic dysfunction is because of persistent nasal pathology, then we have to correct the nasal pathology like deviated nasal septum or eustachic dysfunction if patient want to fly in regularly. So that if you are giving some medication like oral decongestant like solvent cold or Vicodin or any medication decongestant is very helpful. If you are giving 1 hour before the flying, that will decrease the symptom. All other medication like plugging, swallowing, valsalva is not going to be help in this flying. So these are the commonly asked question in the barotrauma patients. So this is all about management of middle ear barotrauma. Thank you so much. Endoscopic anatomy of the middle ear. You can see middle ear, the binocular vision is best in microscope and both hands are free. Endoscopic view wide, fine detail in depth and better depth visualization and have angle depth view. So that point of view, endoscope is better and for free hand and depth of perception is better with microscope. Endoscopically, middle ear divided into 5 parts: epitympanum, protympanum, hypotympanum, mesotympanum, and retrotympanum. Now talk about retrotympanum. Retrotympanum having mainly three ridges: ponticulus, subiculum, and funiculus. The ponticulus is a ridge which is coming from promontory to the pyramidal eminence. Subiculum is a ridge which is going through styloid complex to the posterior pillar of round window, and funiculus is the coming from anterior pillar of round window to the bony covering of jugular bulb. You can see in this picture ponticulus, subiculum, and funiculus. These are the main part of the retrotympanum. Above the subiculum, it's again having four main compartment: lateral to pyramidal eminence and lateral to facial nerve, and anterior to pyramidal eminence and medial to the facial nerve. You can see these four sinuses. Posterior tympanic sinus is just above the pyramidal eminence and below the facial nerve. Behind the facial nerve and lateral to pyramidal eminence is facial sinus, or you can say facial recess, are same thing. But one ridge going anterior and posterior to pyramidal eminence. Anterior is going ponticulus towards the promontory and posteriorly going caudal ridge towards the mustard. So this is the posterior sinus, facial sinus above the pyramidal eminence, lateral to the facial nerve, medially posterior tympanic sinus, and below the ponticulus is sinus tympani, and lateral to facial nerve at the level of sinus tympani below the caudal ridge is the lateral sinus. So this you can see in this picture: lateral sinus, sinus tympani, facial nerve, pyramidal eminence, and just lateral to this pyramidal eminence, this sinus is seen is, that is lateral sinus. So these structure are important in the middle ear. Now retrotympanum posterior sinus. What is posterior sinus? It is a triangular area between the facial nerve and oval window and ponticulus posteriorly. Sinus tympani is round shaped sinus between the ponticulus and subiculum. It's may have shallow type, deep to facial nerve type, and beyond facial nerve, the depth type of the sinus tympani. Sinus subtympanicus below the subiculum and between the subiculum and funiculus. And facial recessive lateral sinuses are lateral to the facial nerve and lateral to the pyramidal eminence. The area between the Facial nerve and funiculus is retrotympanum. From mustard side, you can see this coda facial angle. It is a facial sinus, or you can say facial recess approach. Now talk about epitympanum. Cog divide epitympanum into anterior epitympanum and posterior epitympanum. Cog is coronally oriented bony process project from the tegment tympani to the anterior superior portion of the middle ear, anterior to the malleus head, and anterior to the cochleariformis process. Another is landmark cochleariformis process is osseous projection upon the medial wall of the middle ear. In the anterior part, act as a fulcrum to the tensor tympani tendon. These both landmarks are important for facial nerve identification. You can see in this is Prusak space. It is space between the pars flaccida laterally, lateral process of malleus inferiorly and neck of malleus medially, and lateral malleolar ligament superiorly. You can see this Prusak space. There is anterior tympanic sinus and posterior tympanic sinus. Anterior tympanic sinus which drain anteriorly to the IS joint up to the tensor tympani muscle. Posterior to IS joint up to the mustard process, that is called posterior isthmus, and this space between IS joint and aticomustard air space is called posterior sinus. So these are important for drainage of middle ear. Now talk about protympanum. Protympanum extends superiorly from tensor tympani muscle to the proteiniculum inferiorly. Laterally, this is related to mandibular bony wall and medially up to the carotid bony wall. It's having canal of tensor tympani, supratuber recess, and eustachian tube itself. You can see in this picture. The proteiniculum is arranged between the protympanum and hypotympanum. It may be bridge type, and absent. The lesser petrosal nerve is a branch of the glossopharyngeal nerve. The lesser petrosal nerve convey the preganglionic parasympathetic fiber derived from the inferior salivatory nucleus to the parotid gland. It is composed of fiber from tympanic branch of glossopharyngeal nerve, the nervus intermedius part of the seventh nerve, and auricular branch of the 10th nerve, that is also called Arnold's nerve, and some fiber from the mandibular nerve. So this lesser petrosal nerve is made of the contribution from the glossopharyngeal nerve mainly, then seventh nerve, then 10th nerve, and then some fiber from the fifth nerve. So it is made up of four cranial fibers. The fiber from nervus intermedius and auricular branch of the vagus separate from the seventh nerve as the communicating branch, then join the tympanic branch of the glossopharyngeal nerve in the middle ear to form the lesser petrosal nerve. The lesser petrosal nerve leave the middle ear and enter in the middle cranial fossa through the canaliculus innominatus. So this leaves from middle ear to the middle cranial fossa, that is called canaliculus innominatus. It is a small canal. It runs under the dura and the groove and reaches to the infratemporal fossa, which is really in the aortic ganglia. The postganglionic parasympathetic fiber contribute mainly to the parotid gland. Combined damage of like greater superficial petrosal nerve and lesser is associated with face hyperemia, profuse salivation from the parotid gland, and profuse lacrimation, that is also called crocodile tears, and there is profuse nasal discharge if both fiber are damaged, and this is because of the damage of these fiber and ultimately forming irrelevant regeneration, or that is random regeneration of these fiber when these damage fall, leading to the crocodile ears or profuse nasal discharge. So in conclusion, you can say lesser petrosal nerve is anatomically one of the most complicated nerve in the human, and it is very thin and small, and it follows variable complicated course as in preganglionic part as well as postganglionic, which is conveyed through the auriculotemporal nerve, and it is close relation to the greater superficial petrosal nerve, that is branch of the seventh nerve in the floor of the middle cranial fossa. So this nerve is very important and we know little about it. Thank you so much. Hi guys, today's topic about types of tympanoplasty. There are five types according to Zollner and Bulstein classification. Type first is repair of tympanic membrane without altering the middle ear structure is called laryngoplasty, and type 1 T-plasty. And there is no inspection of middle ear structure during tympanoplasty in type 1 laryngoplasty or tympanoplasty. You can put graft underlay or overlay, it doesn't matter. Type 2 is repair of tympanic membrane with restoration of lever mechanism. If malleus handle is eroded, you are putting the graft over the incus and head of the malleus. That is called type 2 tympanoplasty. Their lever mechanism is re-established by type 2 tympanoplasty. So this is called type 2 tympanoplasty. Type 3 tympanoplasty is having three types: minor, major and steppage columella. If you are putting the graft over the capitulum and the remaining ossicles, it is called minor columellar tympanoplasty type 3. And major, if you are putting there is absent of steppage superstructure and you are putting the graft between the tympanic membrane and the mobile foot plate, that is called type 3 major columellar tympanoplasty. In the steppage columella, if you are putting the graft over the steppage capitulum, it is called steppage columella. Porpage minor, torpage major columellar tympanoplasty. If you are not using anyone, you are putting the over the capitulum, that is called steppage columella. Because columella terms come from birds or reptiles, because birds having only single ossicle, that is columella, and reptiles having single ossicle, that is steppage. So this is type 3 is called columellar tympanoplasty or maryngostupidopexy also. So birds and reptiles having single ossicles, so these terms come from columella. You can see this is the columella single ossicle of the bird in the picture. And type 4 is footplate is exposed to sound and graft over the round window, is called type 4 tympanoplasty. You can see the graft over the round window and footplate is exposed. Type 5th is fenestration of lateral semicircular canal, because footplate is fixed, so you have to put graft where you can make mobile fenestration over the lateral semicircular canal so that sound can be travel through the fenestration. And type 5th V is steppage footplate is removed and graft over the whole window. You can see we are putting the directly graft over the steppage footplate remaining, means over the oval window footplate is removed. So these are the types of tympanoplasty according to Zollner and Bulstein recent classification. So for us it is not very important, for PGs it is very important to know what we are doing and what we supposed to do, and these are the questions commonly asked in the exam. Thank you so much. Fourth compartment is hypotympanum. Inferior to the annulus to the bony covering of the jugular valve is called hypotympanum, depth about 5 to 10 mm. Its extend from funiculus to the protympaniculum, and it's having main component Arnold's nerve and hypotympanic air cell mainly. So this part extends from funiculus to the protyniculum. So this is the hypotympanum area. Last area of middle ear is mesotympanum. It is easily accessible area having cochlea, round window, oval window, handle of malleus and long process of incus is easily visible. So this area is direct vision with 0 degree endoscope. If any small to moderate perforation is there, this area is most accessible by endoscope as well as microscope. So you can see some structure by microscope or endoscope. Almost you can see all structure of mesotympanum. So depth of mesotympanum is 2 mm, hypotympanum 4 mm, and epitympanum having maximum depth about 6 mm. Hi guys, this topic about anatomy of cochlea and the anatomy of organ of Corti. You can see this cochlea is snail-like structure having 2.5 and 2 and 3 by 4 turns. So you can see this is bony and membranous labyrinthine. So the membranous labyrinthine, also called scala media or cochlear duct. Now this cochlea is snake-like structure in inner ear. It about 2.5 and 2 and 3/4 ton, having total length about 30 to 35 mm in length. In this whole cochlea having three compartments: scala vestibuli, scala media, and scala tympani. The scala media is about triangular in shape and half size of the scala vestibuli and scala tympani. And this scala media extends from the spiral lamina to the spiral ligament. And this is also called cochlear duct. The scala media having endolymph and scala vestibuli and scala tympani having perilymph. The apical part of scala vestibuli and scala tympani are connected, that is called helicotrema. This helicotrema is about 8 mm in size. So total length of membranous cochlea is about 8 mm less than the bony labyrinthine, bony cochlea. This basal turn is having middle and apical turn in their lap, and this turn are taking place over the modulus. So from tegmen tympani to the hypotympanum is all is basal turn, and in its lap having the middle and apical turn. You can see the modulus is the conduit of auditory nerve fiber through the spiral lamina or at the base of the cochlea from the internal auditory canal, and this turn of cochlea is on the modulus. So this modulus having auditory fibers. If you putting the cochlear implant up to the middle turn, it is more than sufficient because spiral ganglionic cell population is about 35,000, extend up to the 25 mm length. It's not up to the 35 length. Whole cochlea is 35 length, and this spiral ganglionic cell population is about only 25 mm length. So you are putting the implant up to 25 mm length, it's more than sufficient. This is the picture of modulus you can see, and this is the spiral ganglion cell relative to the cochlear length. And you can see the imaging, the basal turn in the lap of basal turn having lap, the turn of middle apical turn in their lap. And now talk about organ of Corti. So this organ of Corti is hearing receptor of the, its main function is hearing. It's made up by neuroepithelial structure, and the extent of organ of Corti is from spiral lamina to spiral ligament, from vestibular this vestibular membrane, or you can say Rischner membrane, to the basilar membrane. So above is Rischner's membrane, below is basilar membrane, medially spiral lamina and laterally spiral ligament. So this is the extent of organ of Corti. And It is situated in triangular space of endolymph, that is scala media. So scala media having organ of corti, and one membrane is found over the uh, in hair cells, that is called tectoral membrane. This tectoral membrane is a cellular membrane which contain a collagen bundle mainly made up of collagen type 2 bundle, collagen type 5th bundle, collagen type 9th bundle, and collagen type 11th bundles. So this tectoral membrane made by the collagen bundles. If you see cochlea, the inner surface having stria vascularis. This is capillaries which supply the organ of corti. And this is the tectoral membrane over the inner and outer hair cells covering. There is two spaces in cochlea, that is tunnel of corti and space of newel. Tunnel of corti found between inner rod cells and outer rod cells, and space of newel found between the outer hair cells and outer pillar cells. So these two spaces having different type of fluid. Tunnel of corti having cortilymph, while the space of newel having the endolymph, because endolymph containing all fluid that is of the scala media. That is what is in scala media, that is endolymph only. But cortilymph doesn't resemble to the endolymph, it resemble to the perilymph. So this space is cortilymph. You can see tunnel of corti. And there are four type of supporting cells, that is rod cells, or you can say pillar cells, Dieter cells, Hansen cells, and Claudius cells. They are from medial to lateral. First is rod cells, then pharyngeal cells, then Hansen cells, then Claudius cells. Then ultimately there is stria vascularis. So these three types of cells like inner ear cells, outer ear cells, and supporting cell are main structure of the organ of corti. And another is tectoral membrane, and tectoral membrane vibration lead to the impulse transmissions through the stereocilia mechanism. So this organ of corti mainly having three types of cell: inner ear, outer ear, and supporting cells. And this tectoral membrane is made up by the collagen bundle type 2, 5th, 9th, and 11th type of the bundles, and it is acellular hyaline membrane. You can say. Now talk about cell types. The inner hair cells found in the single row, and they are flask in shaped and mainly having apparent auditory fiber. Total number is 3500 only, and outer cells being 3 to 4 rows and found 12,000 number. So the outer cell found in 3 to 4 rows and are they 4 times higher in the number than the inner hair cells. Inner hair cells about 3500 and outer hair cells about 12,000 in number. So 12,000 outer hair cells and 3500 is inner hair cells. Between the outer and inner rod cells is tunnel of corti, I already mentioned, and this outer hair cells mainly having efferent nerve ending. Supporting cells are four types: rod cells, Dieter cells, Hansen cells, and Claudius cells. The outer hair cells are more susceptible to sound or noise and also to the ototoxic drugs. They are more damaged and broken in the ototoxic drug medications, and they produce also autoacoustic emission so that we can identify during the child examination of hearing threshold. If you see the picture of inner hair cells, it is flask shaped, while the outer hair cells being cylindrical in shape. Outer hair cell is sitting in the lap of the pharyngeal process or Dieter cells, and above it is the Dieter cells reticular lamina. Above it, this is the reticular lamina, and this is cell cylindrical cells, outer cells covered by the phalangeal cells, or you can deter cells. The Bakesi traveling wave theory, see the sound going into inner ear and which lead to the basilar membrane friction because of stereocilia mechanism, which by the bending of hair cells, which ultimately generate the impulse which go to the cochlear nerve and ultimately going to auditory fiber. This theory is called Bakesi traveling wave theory. It is mainly because of hydrodynamic pressure of the basilar membrane from base to apex leading to this mechanism. If you see the picture of basilar membrane to the tectoral membrane, they all are situated in three-dimensional space to the pillar cells like hair cells x-axis, basilar membrane is y-axis, and z-axis being the hair cells. So this is all situation of the cochlear hair cells so that they can having space to function. So this is the Bakesi traveling wave theory. Thank you so much. The space of Newell you can see in this picture. It is situated between one side being outer pillar cells and another side being deter cell with their outer hair cell row. So it is a space of Newell which contain endolymph, while the tunnel of Cottai which is between the outer pillar cell and inner pillar cells having cotylymph. The what is space of Newell? The space of Newell is between the outer pillar cells and the phalangeal cells which contain at upper tip is the outer ear cells. So space between outer pillar cells and this deter cells and top of it is the outer ear cells row, and this space between the outer rod cells and this outer ear cells is called the space of Newell, and this space contain the endolymph, while the tunnel of Cottai is situated between the outer hair cells, outer rod cells and inner rod cells. These are also called outer pillar cells and inner pillar cells. So this space is tunnel of Cottai, which is green in color, is containing the cotylymph which resemble to the perilymph. You know this space hole, scala media containing the endolymph, but this cotylymph doesn't resemble to the this endolymph fluid. It resembles to the perilymph fluid, and the space of Newell having the endolymph. And this space first described by the Jean Pierre-Newell. So this is all about space of Newell. Hi guys, today's topic about inner ear malformation, or you can say cochleovestibular malformations. The pediatric SN loss is a major cause of disability, although inner ear malformations account for only 20 to 40% of all cases. Recognition and characterization will be vital for the proper management of these patients. CT and MRI imaging play a crucial role in the characterization and vital for the proper management. The sensory hearing loss in children is a major cause of disability. It can be due to congenital or acquired anomaly. At least 50% are genetic, and among acquired 50%, or you can say 40%, mainly caused by the CMV virus. The cochlear implantation is the standard therapeutic proceeding for severe to profound SN loss. Now talk about anatomy and embryology of inner ear. During third week, the thickening of surface ectoderm on either side of rhombencephalon leading to otic placoid formation. By fourth week, the otic placoid develop a pit that is called otic pit, which closes off at fourth week and form the otocyst. Otoplacoids and now otocyst. The development of cochlea is completed in the 8th week, and the vestibule development complete by 11th week, and semicircular canals complete develops by 19 to 20th 22nd weeks. The first develop is superior cervical canal by 20th week, then posterior semicircular canal, and then horizontal semicircular complete development by 22nd week. The inner ear made up of the membranous labyrinthine that in turns around the osseous spiral labyrinth, and the cochlea responsible for hearing is a conical structure consisting of a duct that make about 2.5 tons around a central core called modulus. You have to remember this osseous lamina in which the cochlea turns around is called modulus. From the modulus, a thin osseous spiral layers reaches out to divide the duct into scala vestibuli and scala tympani. The through cochlear opening, it's cochlear opening also called cochlear aperture or lamina fibrosa. The cochlea meets the fundus of internal auditory canal. The cochlear nerve passes through it. So it is between the cochlear opening between the internal auditory canal and between the cochlea. The vestibular system is made up of the vestibule and the three semicircular canal. The spectrum of disease mainly involve four genes: Dix, SOX, FGF and FOX. These four genes mainly leading to genetic malformation of the cochlea. The latest classification by Senaroglu in 2017, which is worldwide accepted, divide cochlear malformations or cochleovestibular malformation into 8 domains. Now, how cochlea develop and defect at which week develop? The cochlea develop by 3rd to 8th week, and you can see on 3rd week there is complete labyrinthine aplasia or rudimentary otocytes at the 3rd week arrest. 4th week there is cochlear aplasia, common cavity enlarged vestibular aqueduct or cochlear aperture anomaly will be found because of arrest at 4 week. 5th or 6th week leading to cochlear hypoplasia of different types, and 7th or 8th week leading to incomplete partition. Now you can see in this picture there is complete development of vestibule and cochlea. This is normal cochlea, and cochlear aplasia, there is vestibule is fully developed, but cochlear aplasia is there, no cochlear development is there. Common cavity in which the vestibule and cochlea both are less developed. Cochlear hypoplasia is small type of cochlea and it's having mild to severe grade, and incomplete partition it may be mild to severe. Now we will talk about 8 domains separately, which is given by this is Senaroglu classification in 2017. It is latest classification. Now talk about Senaroglu classification. There is 8 domains. Now talk about first domain. Now complete labyrinthine aplasia. It is also called Michel deformity. It's because of 3rd week developmental arrest. There is total absence of inner ear structures. Internal auditory canal is atretic or absent. Facial nerve trajectory is aberrant. And petrous apex hypoplasia, there is absence of petrous apex also, or maybe petrous wall also. The medial wall is completely absent, or promontory is absent on CT or MRI. Now it is also absolute contraindication of cochlear implantation. I put CT scan after this so that you can come to know which type of cochlear malformation, cochleovestibular malformation is there. The complete labyrinthine aplasia is 3 types, with hypoplastic petrous bone or aplastic petrous bone. Without aortic capsule, there is absence of aortic capsule, and with aortic capsule you can see 3 types of complete labyrinthine aplasia. It is absolute contraindication of cochlear implant. And this complete labyrinthine aplasia may associated with the Hoxa mutation, which is vascular anomaly, facial weakness, and hyperventilation syndrome. It may also associated with Lamb syndrome, in which FG3 mutation is there. There is macrotia and macrodontia is also present. Now talk about second classification, that is second one in Senaroglu classification is rudimentary autocyst. It is also called Michel autocyst deformity. It's because of arrest between third and fourth week, and rudimentary autocyst is a very small cystic structure without formation of internal auditory canal. It's also contraindication of cochlear implantation. Now talk about cochlear aplasia. It's also arrest of cochlear structure at fourth week. There is complete absence of cochlea, and here labyrinthine segment of the facial nerve is entirely displaced, and vestibular semicircular canal are fully developed in this cochlear aplasia because it's aplasia of cochlea, not the vestibule. The cochlear nerve is absent. It is two types. First is cochlear aplasia with normal labyrinthine, and second is cochlear aplasia with dilated vestibule and semicircular canal. It's also contraindication of cochlear implantation. So 3. Complete labyrinthine aplasia, rudimentary autocyst, and this cochlear aplasia is absolute contraindication of cochlear implantation. Now talk about fourth division is common cavity. It is first described by Edward Koch in 1838. It's because of 4th to 5th week arrest. The features are, it is defined as single, large, oval, round structure representing cochlea and vestibule. It contains neural elements of the both cochlea and vestibule. Its rudimentary part of semicircular canal can be present. The internal auditory canal is well developed and enters the mid portion of the cavity. It is cochlea and this is vestibule. So this common cavity in middle, it is internal auditory canal is seeing. You can see in CT scan. I will put CT scan also after this. The common cochleovestibular nerve is present. Occasionally separate cochlear nerve may be seen, but most of the time it is common bundle of cochleovestibular nerve. The sixth feature of common cavity is cochlear implantation, effective treatment for the hearing in common cavity. The surgical approach for cochlear implantation is via transmuscular banana shaped labyrinthectomy, which first was described as McElveen et al. As the neural elements are mainly located at the periphery of the cavity, so straight electrodes are preferred. Pre-curved, modular hugging and half-bended electrodes should be avoided. The length of the electrode array required can be calculated prior to surgery by using the formula 2 pi r, where r is the radius of the common cavity. So 2 pi r is the proper length of the electrode array. You can measure by application of this formula. You can see this internal auditory canal. If you draw the line, there is common cavity defect. Okay, so this is cochlear aplasia with dilated vestibule, and this is common cavity. So you can differentiate between cochlear aplasia with dilated vestibule with common cavity by, if you draw the line through the internal auditory canal, there will be no anterior structure to it, so it is cochlear aplasia. So there is no cochlea because cochlear structure are anterior to internal auditory canal. So it is cochlear aplasia where complete development of cochlea is arrested. In common cavity, if you draw the line through internal auditory canal, you will see the cochlea is there, but it is less developed. So, and this is vestibule. So almost it passes between internal auditory canal. You can see two cavities, almost single cavity, but two divisions through internal auditory canal per line. So it is anterior to internal auditory canal, there is cavity, and half cavity is behind. So it is common cavity defect. Now fifth type of Senna-Roglu classification is cochlear hypoplasias. Now, cochlear hypoplasia, in which smaller external dimensions of cochlea can be seen, and cochlear duct length is less than 25 mm, may represent various ways. Hearing may be normal, profound, conductive, or SN loss, or mixed hearing loss. Patient with pure conductive hearing loss, especially with the cochlear hypoplasia 3 and 4, may benefit from STP surgery. The cochlear nerve deficiency is frequent in cochlear hypoplasias. The promontory is flat and round window is visualized, may not be visualized. So there is no round window because the promontory is flat. Facial nerve have anomalous course. And in this, better to use smaller and slimmer electrode, thinner electrode. Now talk about 4 type of cochlear hypoplasia. In first, there is small bud-like cochlea. There is no intrascalar septum or modulus. What is intrascalar septum? This is apical turn, this is middle turn, and this is visual turn. So this is modulus in which this turn take place. So between apical, between the turns like apical, middle, or turn, there is this septum is called intrascalar septum. So this in cochlear first there is small bud cochlea, there is no intrascalar septum, and there is no modulus. So both this modulus and intrascalar septum is absent like this. It is bud-like cochlea. Now cochlear hypoplasia 2 is cystic hypoplastic cochlea. There is absent modulus and intrascalar septum. Vestibule and vestibular aqueduct may be enlarged. There might be defect between internal auditory canal and cochlea. Because of this, there are higher chances of gusher during the surgery. And stapedial footplate defect may present recurrent meningitis, and this full bended lateral wall electrode are used. Now cochlear hypoplasia 3 is shorter and fewer turn cochlea less than 2.5 tons and shorter intrascalar septum and modulus. You can see shorter intrascalar septum and modulus is there. In cochlear hypoplasia 4 is normal basal turn and their fusion of middle and apical turn leading to hypoplastic appearance, and this is facial nerve may be anomalous. So this is 4 type of cochlear hypoplasia 4. Now talk about incomplete partition. It is sixth division. In this group of anomalies where the differentiation between cochlea and vestibule is clear cut, and the differentiating feature from cochlear hypoplasia is that in incomplete partition the cochlea is normal length and it is about 25 mm in size, and cochlea is normal in external appearance, and there is complete formation of cochlea but there is defect inside the cochlea. It is 3 types on basis of intrascalar septum and modulus. Now talk about type 1. Type 1 is cystic cochleovestibular malformation in which normal external architecture of cochlea is there but there is absent modulus and absent intrascalar septum. Dilated vestibule defect between the cochlea and internal auditory canal. No modulus in the nerve ending along the periphery. So west electrode for IP1 is the full bended lateral wall electrode. And big cochleostomy should be done in cochlear implantation. Lead to CSF flow, then you can insert the electrode. Now IP2 is the apical part of modulus and corresponding intrascalar septum are defective. There is cystic apical part because of fusion of apical and middle turn leading to, and this is leading to IP2. Sometimes IP2 incomplete partition 2 is associated with enlarged vestibular aqueduct duct and dilated vestibule. This deformity is called Mondini's deformity. Okay, so IP2 enlarged vestibular aqueduct and dilated vestibule is called Mondini's dysplasia, or you can say Mondini's deformity. It is not like IP2 is Mondini deformity. It is Mondini is only having triad. Okay, so IP2 is different. In Mondini's deformity, there is IP2, enlarged vestibular aqueduct and dilated vestibule is there. In this, hearing loss may be normal to profound and no CSF gusser is there in IP2. Any kind of electrode can be used, and associated, this IP2 is also associated with Pendred syndrome, in George syndrome and Mondini's deformity. Pendred syndrome is SN loss with colloid matter. Okay. Now talk about IP3. IP3 is absent modulus. Interscalary septum is present like this. Interscalary septum, but there is no modulus. Okay. And it is mainly X-linked deafness, and defect between the internal auditory canal and cochlea is there. There is 100% chances of the gusser, and in which the full bended lateral electrode is used, and facial anomaly may be associated with IP3. You can see difference between IP1 to 3 according to interscalary septum and modulus. There is in first both interscalary septum modulus absent, and IP2 there is interscalary septum is absent but modulus is present, and IP3 the interscalary septum is present but modulus is absent. It because it's excellent. You can see I have already told the detail of each and every IP3. Now come to the seventh division. It's enlarged vestibular aqueduct. It is one of the most common inner ear malformations. Vestibular aqueduct is enlarged, and vestibular aqueduct is a bony structure in which contain the endolymphatic duct, which connect the inner ear to the endolymphatic sac to the posterior cranial fossa. Various criteria for enlarged vestibular aqueduct. Large, according to Balvasuri in Clemens, it is most commonly accepted classification in which the midpoint of the width is more than 1.5 mm. It is midpoint between the operculum and the vestibule. If you measure the width, you will find if it is more than 1.5 mm, it is enlarged vestibular aqueduct. Cincinnati in 2007 told width is midpoint is more than 0.9 mm. At operculum level, if it is more than 1.9 mm, it is called dilated. In Wilson's criteria, any segment of vestibular aqueduct adjacent to posterior canal, if it is more than the diameter of posterior semicircular canal, twice the diameter of any canal, horizontal, posterior, semicircular, it is most likely dilated enlarged vestibular aqueduct. An enlarged vestibular aqueduct can be sign of genetic disorder like Pendred syndrome, in which the progressive hearing loss associated with goiter. Now talk about this cochlear aperture anomaly, also known as cochlear faucet anomaly. Okay, the cochlear aperture, it is a bony cochlear nerve canal in which the cochlear nerve is passing through, carries the cochlear nerve between the internal auditory canal and modulus. The atresia or stenosis of cochlear aperture correlate with the cochlear nerve deficiency. The cochlear aperture normally equal to or more than 1.5 mm at mid portion or mid modular width. Cochlear aperture stenosis defined when mid modular width is less than 1.5 mm. When cochlear aperture is not visible and it is occluded, so it is called atretic. There is cochlear nerve is absent most of the time. Approximately 33% of ear with bony cochlear nerve canal stenosis also had a hypoplastic or aplastic cochlear nerve. All patients with bony cochlear nerve canal atresia had cochlear nerve deficiency. I already told you. The cochlear nerve was hypoplastic or aplastic when the diameter of internal auditory canal was less than 2 mm. Cochlear aperture can be normal, hypoplastic, aplastic or wide. Cochlear aperture aplasia, hypoplasia are most commonly seen with Charles syndrome. Now new classification, easy to remember classification for like Senaroglu put for cochlear vestibule or cochleovestibular malformation, or you can say inner ear malformation. So this is very simple classification. This Savai Mansingh classification on name of SMS. This classification is easy, provide uniformity, enables treatment planning, and allow the prediction of complication and prognosis. So this SMS classification of cochleovestibular malformation took cochlear morphology, the modulus and lamina cabrosa consideration to divide the cochleovestibular malformation into 6 types. First is A, B1, B2, C1, C2 and D. So it is 6 types according to cochlear morphology, modulus, lamina cabrosa and associated anomalies. In type A, there is normal cochlear morphology, normal modulus and normal cochlear aperture, you can say lamina cabrosa, normal. It is having isolated syndrome like enlarged vestibular aqueduct. So it is type 1A. B1 is in which cochlear morphology is abnormal, smaller modulus in normal lamina cabrosa. In B2, there is abnormal cochlear morphology, defective modulus and normal lamina cabrosa. In C1, there is abnormal cochlear morphology, absent modulus or normal lamina cabrosa. In C2, there is abnormal morphology, absent modulus or absent or deficient lamina cabrosa. So lamina defect start at C2 level. And D is absent cochlear structures, modulus is also absent, lamina cabrosa is also absent. It may associate with cochlear nerve malformations. So this is 6th division according to the Savai Mansingh classification. If you put Senaroglu with this, you can see in A type there is isolated anomaly of semicircular canal or enlarged vestibular aqueduct and comes in A1. B1 is cochlear hypoplasia type 3 and 4th. B2 is cochlear hypoplasia 2. C1, C2 having IP1 common cavity, IP the cochlear hypoplasia 1 and 2 type, and C2 having incomplete partition 3 common cavity, cochlear hypoplasia 1 and 2. D having complete labyrinthine aplasia, rudimentary autocyst and cochlear aplasia. So this D is contraindication of cochlear implantation. So it is easy to remember, but worldwide following the Senaroglu classification. Now comes about one by one. In cochleovestibular malformation type 1, you can say type A, in which normal cochlea, it involves extracochlear part of labyrinthal like dysplastic vestibule, absent semicircular canal or enlarged vestibular aqueduct. All type of electrode can be used. Surgery is the same as that of normal cochlea, except the mid-perilymph oozure is seen in enlarged vestibular aqueduct. Results are the same as normal cochlear implantation is done in this case. Now cochleovestibular malformation type B according to SMS classification. This is cochlear morphology is not normal in this. Modulus is present, however in B1 the modulus is complete but smaller. In B2 the partially defective modulus is upper half of the cochlea. The lamina cabrosa is normal, so there is no communication between the internal auditory canal and cochlea. All electrode can be used. Surgery is the same as that for normal cochlea, except mild perilymph oozure can be seen. Results are same as normal cochlea. CMB type C, there is cochlear morphology is abnormal, Modulus is absent, lamina fibrosa is normal in C1 and deficient absent in C2. As there is no modulus, the nerve ending are along the periphery of the cochlea, so full bended lateral wall electrode should be used. The chances of CSF gusher are high in type C2. Their surgeon should be prepared for dealing with it. There should be bigger cochleostomy done. Let the CSF flow out and you can put form electrode in which the proximal part of array having conical stopper so that it can stop the CSF gusher or CSF flow. The good sealing of cochleostomy by tissue should be done, and sometimes subtotal petrosectomy may be required. In type C2, due to big communication between the internal auditory canal and cochlea, there are chances of electrode error may be misplaced in internal auditory canal. Therefore, a cross check should be done by with sham or X-ray, so you can withdraw the electrode. Okay. And sometimes you may use fluoroscopy guidance to put the electrode because there is gap between internal auditory canal and cochlea. In CMB type D, where which cochlea is absent, vestibular component may not be normally developed, and cochlear implantation contraindicated. All patients require auditory brainstem implant in type D. Now come about some talk about on cochlear nerve anomalies. According to Kesselman et al., describe cochlear nerve hypoplasia or aplasia based on its dimension in relation to ipsilateral facial nerve is about 64% of cases, and relative size of forenerve is symmetrical with contralateral symmetry is about 70% of cases. So you can see cochlear nerve size is correlated with spiral ganglion cell population, and thus it helps predict the outcome of cochlear implantation. So you should see the symmetry of cochlear nerve also and development of cochlear nerve before putting the cochlear implantation. Kesselman came with classification with divided cochlear-vestibular nerve anomaly into following 4 types. In type 1, there is no cochlear-vestibular nerve is seen, only facial nerve is present. In type 2A, there is absent cochlear nerve and dysplastic labyrinthine is there. In type 2B, absence of cochlear nerve with normal labyrinthine. And type 3, there is isolated aplasia of vestibular nerve. It's never reported. So this is Kesselman classification. But newer classification of cochlear nerve anomaly is by Senaroglu, which divided into 6 types. In first, there is normal cochlear nerve. In type 2 is smaller cochlear nerve with smaller cochlear nerve than the facial nerve dimensions, and bony cochlear nerve canal is stenotic or atresia is present. Now type 3 is there is no cochlear nerve. Type 4 is in which single bundle of cochlear-vestibular nerve is there. There is no differentiation between cochlear and vestibular nerve. There is single nerve. And type 5 is hypoplastic cochlear-vestibular nerve. This type 4 and 5 found mainly in common cavity. And there is type 6 is absent cochlear-vestibular nerves, in which the both cochlear and vestibular nerve is absent in type 6. So it's seen in the Michel deformity, you can say in the complete labyrinthine aplasia. So this talk about cochlear vestibular malformation. Thank you so much. Hi guys, this is topic about inner ear malformation and cochleovestibular malformation. Pediatric external loss is a major cause of disability. Although inner ear malformation account for only 20 to 40% of all cases, recognition and characterization will be vital for proper management of these patients. CT and MRI imaging play a crucial role in the characterization will be vital for the proper management. Sensory hearing loss in children is a major cause of disability. It can be due to congenital and acquired anomaly. At least 50% have a genetic origin, and among acquired ones, the CMV virus is most common cause. The cochlear implantation is a standard therapeutic proceeding for severe to profound SN loss. Now talk about anatomy and embryology of penaria. During third week, the thickening of surface ectoderm on either side of the rhombencephalon resulting to form aortic placoid. At fourth week, it develop an aortic pit, and after some time, aortic pit is disappear, lead to autocyst formation. At fourth week, this development of cochlea completed at eighth week, and by vestibule developed by 11th week, and semicircular canal developed by 19th to 20th week to 22nd week, and its superior canal developed, then posterior canal developed, and at last horizontal semicircular is developing. The inner ear made up of the membranous labyrinthine, that is about 2.5 tons, and this turns around the modulus, and osseous spiral layer reaches out to divide the duct into scala vestibuli and scala tympani. Through cochlear opening, there is also called cochlear aperture or lamina fibrosa. The cochlear meets the fundus of internal auditory meatus. The cochlear nerve passes through it, and there is a spectrum of cochleovestibular genes, which is mainly Dix, SOX, FG, FOX. These are four common genes involved in genetic malformations. You can see cochlear development in this phase, third to eighth week is completed. You can see normal cochlea, cochlear hyplasia, common cavity, cochlear hypoplasia, incomplete partition. Okay, so according to Senga-Gluru, this classification is having 8 domains. First is complete labyrinthine aplasia, or you can call it Michel deformity. It's because of arrest of development of cochlea on third week. So this is first type. There is total absence of inner ear structure. Internal auditory canal is atretic. Facial nerve is trajectory is aberrant. In petrous apex, hypoplasia may be seen. There is no development of petrous box. It is three types: with a hypoplastic petrous bone, without aortic capsule, or with aortic capsule. So three types of complete labyrinthine aplasia is there, and sometimes it is related to Lamb syndrome, that is FG3 FGF3 mutation. You can see in this picture there is complete labyrinthine aplasia. In this picture there is no proper development of petrous bone. Second is rudimentary autocyst. This is also called Michel autocyst deformity. It is arrest of development of third to fourth week, and you can see only a small cyst there. It is also contraindicated of cochlear implantation. You can see there is a small autocyst which is not developed in the cochlea. Now third is cochlear aplasia. It is arrested fourth week, and there is absence of cochlea, where labyrinthine is well developed, vestibule may be fully developed, and semicircular canal also fully developed. You can see cochlear aplasia. There is two types: cochlear aplasia with normal labyrinthine, and cochlear aplasia with dilated vestibule or semicircular canals. It also contraindication of cochlear implants. So three: complete labyrinthine aplasia, rudimentary autocyst, and cochlear aplasia are contraindication of cochlear implantation. Now common cavity. It is first described by the Edward Koch in 1838. It is defined as single large ovoid round structure representing the cochlea, contain neural element of both cochlea and vestibule as a common cochleovestibular nerve, and internal auditory canal is well developed, entering the mid portion of this cavity. And it's also, you can do cochlear implantation. You can see in this CT scan there is common cavity is there, in which the internal auditory canal is passing. There is nerve also well developed. You can see in this picture. And neural elements are mainly located at periphery of cavity. So a straight electrode are preferred because Pre-curved modular electrode hugging half-bent electrode should be avoided because straight electrode is better. Now cochlear hypoplasia. It is a smaller external dimension. A cochlear duct length is about less than 25 may present various ways. It is mainly four types: cochlear hypoplasia 1, 2, 3, and 4. One is having a small bud with cochlea. There is no interscalar septum or no modulus. Cochlear hypoplasia 2 is cystic hypoplastic cochlea, absent modulus and absent interscalar septal. Vestibule and vestibular aqueduct may be enlarged. There might be a defect between internal auditory canal cochlea and stapedial foot plate defect may be having meningitis. You can see this in this cochlear hypoplasia. You can see each cochlear hypoplasia 1, 2, 3 in this CT scan. Cochlear hypoplasia 3 is shorter and fewer cochleator less than 2.5 and shorter interscalar septum and modulus. In cochlear hypoplasia 4 is normal basal turn and middle and apical turn are hypoplastic. You can see in this picture, and facial nerve anomaly may be present in this. So cochlear hypoplasia 1, 2, 3 and 4 you can see in this picture. Now incomplete partitions. In this group of anomalies where the differentiation between cochlea and vestibule is clear cut, and the differentiative feature for cochlear hypoplasia is that in this incomplete partition cochlea is normal in length and maybe larger in size more than 25 In incomplete partition 1, you can see cystic cochleovestibular malformation, no normal external architecture but absent modulus and absent interscalar septum is there. There is no modulus and nerve ending on the periphery, so better electrode is full bended electrode on lateral wall is effective. Big cochleostomy let the CSF flow and the electrode insertion can be done. You can see in this picture. IP2 is apical part of modulus and corresponding interscalar septum are defective. Cystic apical part due to fusion of apical and medullary can be seen. So and IP3 there is absent modulus and interscalar septum present. It is mainly excellent. Defect between internal auditory canal cochlea is present. And full bended lateral wall electrode can be used. In large vestibular aqueduct, you can see if its vestibular duct is more than 1.5 it is enlarged vestibular aqueduct. It may be found with associated anomaly or alone in the development. It is 7th type of inner ear malformation. You can judge by the diameter of the according to Valsori in Clemish, the midpoint width is more than 1.5 so it is enlarged vestibular aqueduct. Now come to the cochlear aperture anomaly. If it is cochlear aperture, bony cochlear nerve canal is less than 1.5 in size, so it is the cochlear aperture anomaly. Now Savai-Mansingh classification divided into A, B, C, D, and V again V1, V2, and C again C1, C2. So total 5 classes are there. 6 classes: A, B1, V2, C1, C2, and D. You can see according to cochlear morphology, modulus, and lamina fibrosa. So it's better and standard classification to do the easy classification. You can see not better but easy classification. Now CMB type 1 cochlea is normal and there may be enlarged vestibular aqueduct associated anomaly may be there. And cochlear nerve anomaly may be there, like Kesselman et al. Describe cochlear nerve hypoplasia or hypoplasia in ipsilateral facial nerve is about 40% of the cases. The relative size of nerve is symmetrical with the contralateral internal auditory canal is 70% is symmetrical. And Cashernal again divided into cochlear nerve anomaly in four types: one, 2A, 2B, and third. No cochleovestibular nerve seen and facial nerve is present. Second is absence of cochlear nerve with dysplastic labyrinth, and second is absence of cochlear nerve with normal labyrinth, and third is isolated aplasia of vestibular nerve can be seen. So this classification is all about cochlear nerve malformation. And this is classification, another classification 1 to 6 type of cochlear nerve anomaly. It is by Sena Roglu. So this is all about inner ear malformation. Thank you so much.